Hello, welcome to Chapter 29, Development and Inheritance. We're going to look at what exactly happens right after fertilization of that secondary oocyte, what happens then. And then we're also going to look at how we inherit different traits. So those gametes, that's those sperm, and those secondary oocytes, they come from the testes and the ovaries. Sperm, millions upon millions of sperm get released into that female genital tract on ejaculation. Only a few can make it to that secondary oocyte that has been released from that ovary to be fertilized. Pregnancy is all of the events that happen between fertilization, that implantation, embryonic development, fetal development, and it ends between 38 to 40 weeks later with delivery. They usually count between 38 to 40 weeks after the mother's last menstrual period, to determine a baby's due date. So that embryonic period is going to be from fertilization through the 8th week. So this is the embryo that is developing. Fetal period is 9 weeks to birth. They are known as the fetus. This prenatal development is technically from fertilization to birth. It puts together the embryonic and fetal periods, and we divide them into trimesters. So the first trimester, it's usually that most crucial stage because most organs are developing. The brain is developing, the heart is developing in these first 8 weeks. So they're very vulnerable. So drugs, radiation, microbes, they can all affect how this embryo develops. That second trimester, by now, most of the organ systems have developed. They're just maturing. They're starting to develop more human-like features. And then that third trimester is rapid fetal growth. They grow very fast. They'll double in size, and their organs start to become fully functional during this third trimester. So at fertilization is when that haploid sperm and that haploid secondary oocyte come together and form that single diploid nucleus. Haploid meaning they have half the chromosomes of a normal cell. So that sperm has one half of the chromosomes, that secondary oocyte has the second half of the chromosomes, and they come together. So 2 million sperm usually enter the vagina. Not even 2 million of them will make it to the cervix. Maybe 200 will make it to that secondary oocyte. Fertilization is going to occur in those uterine tubes between 12 to 24 hours after ovulation. Sperm can remain viable for about 48 hours after they have been deposited into the female reproductive tract. That secondary oocyte is only viable for 24 hours after ovulation before it gets reabsorbed. So pregnancy is likely to take place if this intercourse happens during a 3-day window, 2 days before ovulation and 1 day after ovulation. So that sperm is going to go through the uterus. It's going to enter into those uterine tubes. those uterine tubes have that smooth muscle in there that does contractions. The prostaglandins that are found in the semen, they're thought to actually stimulate the contractions of these uterine tubes to help the sperm get to the oocyte quicker. So those sperm, because of these contractions, they're within that area of that oocyte within minutes. It takes 7 hours for fertilization to happen. Sperm are going to go through capacitation. They lose, or their tail first beats even more. It beats more vigorous. It's trying to get itself ready to get to that oocyte and fuse with that oocyte. There's different secretions in that female genital tract that remove cholesterols, glycoproteins, and proteins from the plasma membrane around that head of that sperm. So only sperm that have been capacitated, they're the only ones that are actually attracted and respond to these different chemical factors that are being given off by this secondary oocyte. So if fertilization occurs, that sperm has to penetrate that corona radiata, that zona pellucida, and then these to even allow fertilization to happen. On the top of the sperm, they have that acrosomal enzymes. These enzymes in the tail moving back and forth are what helps the sperm to penetrate into that corona radiata and come in contact with that zona pellucida. So there's different glycoproteins that are found in the zona pellucida, and they act as the sperm receptor. Sperm binding to these glycoproteins actually triggers that acrosomal reaction. This causes the acrosomes to be released, all those enzymes. They're going to make a path through that zona pellucida, and that sperm tail lashing back and forth helps to push that sperm even further into that zona pellucida. So only the first sperm that can enter that zona pellucida is able to reach that oocyte's membrane and fuse with that oocyte. By the time one sperm has gotten through that entire zona pellucida to that membrane, the rest of this membrane is kind of fused off, so nothing else can get in. So we can see the corona radiata, a lot of these sperm that are left here have made their way through. They're going through the zona pellucida. Only one has made it through the zona pellucida and into that plasma membrane and into that cytoplasm. Here we can see the sperm that is penetrating into that secondary oocyte. We can also see what happens afterwards. We have what is known as a pronuclei. This pronuclei is of this male and this female's genetic material coming together. So in the very first week, this very first week is when this oocyte is still in the uterine tubes, making its way down towards the uterus. That sperm making it inside that secondary oocyte is going to start polyspermy. If more than one sperm will fertilize that one oocyte. We're trying to block it. So we're trying to prevent more than one sperm getting in. We don't want polyspermy to happen. So within a few seconds, this membrane is going to depolarize. And this is what works as a block to that polyspermy from happening. The sperm, as long as this membrane is depolarized, the sperm cannot penetrate it. It also triggers calcium ions to be released. It stimulates exocytosis of different secretory vesicles to fuse with another sperm. It triggers intracellular release of calcium ions. Then there's molecules that are released in this exocytosis that makes that entire zona pellucida hard. That also blocks more of that polyspermy. So after that sperm has entered that secondary oocyte, this is where that secondary oocyte needs to finish meiosis 2 before anything else can happen. So this oocyte quickly finishes off its meiosis 2. So it's going to divide into a larger ovum, and then that's that second smaller polar body, which is going to disintegrate. So the nucleus in the head of the sperm becomes that male pronucleus that we saw on that slide before, that picture. The nucleus of the female becomes that female pronucleus. So after these two pronucleuses form, they're going to fuse. This is what forms a diploid nucleus, or synagamy. This is what gives this new cell 46 chromosomes, 23 from mom, 23 from dad. Once fertilized, we now have a zygote. Dizygotic twins. This is produced when there's two secondary oocytes that get released and they both get fertilized, each by different sperm. These children are the same age. They develop in the uterus at the same time, but genetically they're not the same. They can even be different sexes. Monozygotic twins. This is where a single fertilized ovum gets fertilized and they have the exact same genetic material. They are always the same sex. When these cells start to divide and separate, there ends up being two different embryos that develop. And this usually happens before 8 days have passed. If it happens after 8 days, this is where conjoined twins come into play. They're still together. They can share some of those same body structures when they are born. So cleavage of the zygote. So this is still happening in the first week. What we are doing is mitotic cell division. So one cell divides to two, two cells divide to four, four cells, 16, 16 cells, and so on. They keep dividing. So that first division takes place about 24 hours after that fertilization, and it takes 6 hours to do. Each time the cells divide after that, it gets faster and faster and faster. By the second day, That second cleavage has happened, so now we have 4 cells. The third day, we have 16 cells. And these cells produced by this cleavage are known as a blastomere. And as this cleavage will produce a solid sphere. This is known as the morella. It still has the zona pellucida that is surrounding, and it's about the same size as that original zygote, that original cell from what we started with. So if we look, we get this cleavage of these 2 cells. One cell turns into 2 cells. Those are those blastomeres. Now we have 2 cells. Each of those 2 cells are going to divide. Now we have 4 cells. By day 4, we've got lots and lots of cells. It's still about the same size. This is where we turn into that morella. Those blastomeres. I want to make sure those were. And then by day 5, these cells are continuing to divide. We get this blastocyst. This is all cells all the way around, just one big ball sphere of cells. After this happens, this blastocyst, we have created this cavity inside. This cavity, these cells are now tropoblasts. And this collection of cells is the embryoblast. These are all coming together as we are forming this zygote. So by that 4th day, the number of cells in the morella are continuing to increase, continuing to divide. We are still moving through the uterine tubes towards the uterine cavity. So this morella, once it enters the uterine cavity, it's about the 4th or 5th day, glycogen starts to be released from this endometrium, which is helping to provide what is known as the uterine milk. It's providing nutrients for that blastomere of the morella. By the time we're at 32 cells, we have fluid inside that morella starting to come. So we have those blastomeres, and then we have that blastocyst cavity. Once this blastocyst is formed, we have hundreds of cells. We have this developing mass, but it's still the same size as the original zygote. It has not started growing larger yet. So this is where we start to get this embryoblast, which is that mass of cells. This is what will create this embryo. We have that tropoblast, that whole sphere around. This is what will develop into part of that placenta and that chorionic sac that embryo is in. So that 5th day, that blastocyst is going to hatch from that zona pellucida. So it makes a hole with these different enzymes, and it kind of sheds it off. They need to shed off this zona pellucida, so we're able to go through and implant into that uterine wall. So that blastocyst kind of remains free for about 2 days in the uterus. But this uterus wall, it's in this secretory phase. So 6 days after fertilization, this is when this blastocyst first starts to kind of loosely attach to that endometrium. This is known as that implantation. So that blastocyst, it's either going to attach to the posterior portion of the fundus at the top or the body of that uterus. And it's going to take that cell mass and face that cell mass towards the endometrium. By day 7, that blastocyst attaches even more firmly. This is where endometrial glands, wherever this blastocyst is attaching, will enlarge. We get more blood vessels that come to that area. This blastocyst secretes more enzymes. It's going to burrow into the endometrium. So after implantation happens, the functional layer of the endometrium, the decidia starts to separate. So different regions of this decidia are starting to be named just based on where they are in relation to this actual implanted blastocyst. We have the basal decidia, which is beneath. So there's a lot of glycogen and lipids available here for that embryo and later fetus. It'll also become the placenta. Capsular. This will cover the embryo after it's been implanted. It'll eventually disappear when this fetus gets large enough. It's around 27 weeks. And then we have the parietal delucida. It's kind of a line that separates the involved area from the uninvolved area in the uterus. So this blastocyst starts to attach to this endometrium. We have some of these endometrial glands that are releasing out different substances. Eventually, you can see how it is originally started to implant. We see this tropoblast. The embryoblast is all of these cells. And then the tropoblast or the blastocyst cavity. What comes in, eventually, we have burrowed underneath the wall. We're inside of that endometrium now. We have this basal decidia. That is what is going to become that placenta eventually. We have our capsular, that's covering everything up, and then that parietal is just further away. It's a separation between what's involved, the area involved in the uterus and the area that is not involved. This is where there's a lot of really cool research about stem cells and therapeutic cloning. Some of this stuff is a little sci-fi. It's probably the best way to put it, but a stem cell is technically an unspecialized cell that can divide indefinitely, and it can give us specified cells. So we can have totipotent stem cells. They can form almost all of these 220 types of cells we have in our body. Pluripotent stem cells. These are in an embryo that is more than 5 days old. They're derived from these totipotent stem cells. So they still can form many of the different cells in our body, but they cannot become the placenta, the chorion, umbilical vesicle, or the umbilical cord. And then we have the multipotent stem cells. These are the ones that can differentiate into a group of closely related cells, like those mesenchymal cells. Those are prenatal connective tissue cells. So they differentiate into all the different types of connective tissue. Oligopotent stem cells, these are pretty specific. Myeloid stem cells or lymphoid stem cells, and we have unipotent stem cells. They can only become one type. So epidermal or spermatogonia. Stem cell research right now is used through bone marrow transplant only, just because there's a lot of different ethical reasons about some of this stuff. So they take bone marrow cells. They tend to replace them from somebody who's had bone marrow cancer. So there's been radiation, chemotherapy, or somebody who has diseased bone marrow. A lot of times it's leukemia, because leukemia affects white blood cells and it's usually affecting bone marrow. So that red bone marrow, it can differentiate into different of cells of the liver, kidney, heart, lung, skeletal muscle, skin, organs of that gastrointestinal tract. So an adult stem cell from the red bone marrow, we could harvest it from a person, and then we can, in theory, use it to repair other tissues or organs that a patient that they need without having to use stem cells from embryos. This is where ethics comes into play, because they could take embryos and take stem cells from embryos of these developing embryos to scientifically use. Using adult red bone marrow doesn't have the same ethical concerns that an embryo does. So we use these stem cells to treat different lymphomas, some types of anemia. It's people who have severe immunodeficiency disease. So most of these people don't have an immune system at all. Multiple myeloma, neuroblastoma. And they're also looking at ways to treat autoimmune diseases where your immune system doesn't identify self from non-self anymore. So your immune system attacks the self. An ectopic pregnancy. This is where that embryo or fetus is growing outside of the uterine cavity. So when that secondary oocyte gets released, it does not get caught up into those uterine tubes. It falls into that pelvic cavity. It could be because of scarring. Those uterine tubes, that smooth muscle just doesn't move, or you could have abnormal tubal anatomy that can cause this. Most common site is actually in that uterine tube. That ovum or that zygote will attach and burrow into the wall of the uterine tube instead. It can also happen at the ovary, anywhere in that abdominal cavity, and at that cervix. These are areas where if these cells start to divide and start to grow, it could cause a lot of problems. That uterine tube could eventually burst open. We're not getting enough nutrients in that abdominal cavity, that cervix. So women who smoke are twice as likely to have an ectopic pregnancy, because nicotine paralyzes the cilia in that uterine lining or those uterine tubes. Someone who's had at least one up to two missed menstrual cycles, but then they start having bleeding and abdominal or pelvic pain, just depending on where this zygote has now attached itself. They need to remove it. It can rupture those uterine tubes, as I said, and when that happens, that results in the death of the mother. So there's treatment. The treatments would be surgically going in and removing this ectopic pregnancy. There's a cancer drug, methotrexate, and this will stop embryonic cells from developing. So it's another way to treat this. So 8 days after this fertilization has occurred, this trophoblast will develop 2 different layers. We get that syncytiotropoblast, and we get this cytotropoblast. This syncytiotropoblast is between that embryoblast and that syncytiotropoblast, and it has different, like, distinct cells. We can tell the difference between the 2 types of cells. These 2 layers become the chorion as they continue to grow. That syncytiotropoblast is going to secrete enzymes, and it allows that blastocyst to penetrate the uterine lining because it's going to liquefy part of those cells. That's what allows this blastocyst to bury itself in that endometrium. The tropoblast also starts to secrete that human chorionic gonadotropin, that hormone. We also that's what saves that corpus luteum, that area where the secondary oocyte was released out. So we keep that from degenerating. So that can keep those levels of progesterone and estrogens high enough to keep that uterine lining. It prevents that menstruation. This HCG peaks at about 9 weeks of pregnancy. That is when the placenta is fully developed. By that point, the placenta can produce the progesterones and estrogens that are needed to maintain that pregnancy. So now we're developing this laminar embryonic disc. This embryoblast will differentiate into 2 layers, that hypoblast, which is that endoderm, that epiblast, which will become that ectoderm. These 2 layers are known as that bilaminar embryonic disc. We also get a cavity. This cavity is going to form the amniotic cavity. So this amnion that is being developed, the amniotic cavity is going to continue to enlarge. We have a layer of these squamous cells that are going to form at the roof of that amniotic cavity. The amnion is going to lay over top of that bilaminar embryonic disc. That's going to continue to increase in size. It starts to fold. The amnion is going to surround the entire embryo. That's what creates that amniotic cavity, and it starts to fill with amniotic fluid. And it's mostly from the maternal blood. But the fetus will contribute later, as that fetus is after 9 weeks. The amnion is going to regulate the fetal body temperature, prevent that fetus from drying out, prevents adhesions between the skin and the surrounding tissues. This ruptures just before birth. So here we can start to see all of these different layers developing. We have this amnion with that amniotic cavity. We start to see that centriotropoblast, that cytotropoblast. All of these different cells here through here are all being developed. Everything continues to thicken. More layers of cells are being developed here. We still have that amniotic cavity with that epiblast and that hypoblast now. So we have those two layers of cells, the epiblast and that hypoblast with that amnion and that amniotic cavity. This is all forming. And then what we have here, this open area, is this umbilical vesicle. So on this 8th day, those cells at the hypoblast, they start to migrate and cover the surface of the blastocyst. This is the extra embryonic endoblast. So that hypoblast, the exocoelamic membrane is going to form the walls of those umbilical vesicles. That's also can be known as the yolk sac. This is what gives that bilaminar embryonic disc. And it is positioned between that amniotic cavity and that umbilical vesicle. Embryos get their nutrients from the endometrium, the umbilical vesicle. So those 2nd and 3rd weeks of development, we're getting all of our nutrients from that umbilical vesicle, and then blood cells from the 3rd through the 6th week. The first cells will eventually migrate. Those are what are going to develop into those gonads. So those primitive germ cells are going to form gametes. We'll get that digestive canal starting to form. So these different sinusoids that are starting to develop. So on the 9th day after fertilization, this blastocyst is completely embedded. That cytiotropoblast, as it becomes completely embedded, it has these vascular circles. Those endometrial capillaries, they start to become dilated, forming sinusoids. That cytiotropoblast is going to kind of erode some of these maternal sinusoids and these endometrial glands. Maternal blood and secretions from these glands are actually what's going to help provide nutrients. And it gives a disposal site for the wastes from that embryo as everything is starting to develop. That extra embryonic column, that's by that 12th day. That extra embryonic mesoblast mesoderm starts to develop. So these mesoblast cells, they come from that umbilical vesicle, the connective tissue layer, that mesenchyme, and that amnion and umbilical vesicle. Area of this cavity and that extra embryonic mesoblast will fuse. And this is known as that extra embryonic column. That chorion. So we get that extra embryonic mesoblast, has those 2 layers. We have a tropoblast that forms the chorion. That chorion wraps all the way around that embryo, later the fetus. It's going to become part of that placenta. It works to protect the embryo and the fetus because the mother's immune system may come and attack. This chorion prevents that from happening. It helps to secrete different proteins that block antibodies. It promotes T lymphocytes. T lymphocytes are going to suppress immune responses in the uterus specifically. That chorion is going to continue to produce that human chorionic gonadotropin. That inner layer will fuse with that amnion. So by the second week of development, we have that bilaminar embryonic disc. It connects to the tropoblast by that extra embryonic mesoblast, that connecting stalk, which will be that umbilical cord in the future. So we're going into the third week of development. And at the third week, we start a 6-week period. So from 3 weeks to 9 weeks, technically that 3-week period or 6-week period, we have rapid development and differentiation. Gastrulation is about day 15. That bilaminar embryonic disc turns into a trilaminar embryonic disc. That's where we get that ectoderm, mesoderm, and endoderm. Those are our primary germ layers that have been mentioned in every system chapter, or chapter for every system that we covered in Anatomy 1 and Anatomy 2. We're going to have these rearrangement of tissues, and we're going to form this primitive streak. That gives us the head and tail ends of that embryo. So the head end, we have this small group of cells that are going to form this primitive node. The primitive stalk, those cells in the epiblast are going to move below this primitive stalk or streak, and it's going to detach. And it's going to cause this invagination, which will cause this hypoblast to form the endoderm. So as these cells remain between the epiblast, which form the endoderm, which will cause the mesoderm to form. Those cells of that epiblast will form that ectoderm. Ectoderm and endoderm are epithelial cells. The mesoderm is connective tissue. So that endoderm becomes that epithelial lining of your digestive canal, respiratory tract, and most of your other organs that have some sort of epithelial cells lining them. That mesoderm, that connective tissue, so muscle, bone, other connective tissues, the peritoneum. Ectoderm gives us our skin, nervous system. So 16 days after fertilization, those mesodermal cells form the primitive node, or from the primitive node, are actually going to go towards the head of that embryo, and then it starts to form a tube. This is the notochordal process. Between 22 and 24 days, this notochordal process is going to become a cylinder of cells. The notochord. This is where that nervous system starts to come from. So now we're coming across pictures that we'll start to have seen here soon. So we still have that amnion with that amniotic cavity. We have that umbilical vesicle. We have that cytotropoblast, extra embryonic mesoderm, that hypoblast, that epiblast, that's that bilaminar embryonic disc. Now, the next stage, we form a tail end and a head end. We have that primitive node, so that amnion, that connecting stalk. We start to get that bilaminar embryonic disc. We start to get the oropharyngeal membrane. The umbilical vesicle is coming in, that primitive streak with that bilaminar embryonic disc. Now we're starting to build new cells coming in the middle here. Those new cells in the middle about week 16, this is where we get that ectoderm, mesoderm, and endoderm. And after 16 days, we have that trilaminar embryonic disc now as these cells just continue to develop. We're starting to get those notochordal processes, that neural plate, that primitive node, that primitive streak. We still have that tail end and that head end with that connecting stalk. That umbilical vesicle, that connecting stalk is continuing to grow. We still have that notochordal process, that mesoderm. So here's these 3 primitive germ layers that we've mentioned in every system and all of the different things that they are going to turn into. There's a lot of different things listed here, but it's everything in the body. So as I pointed out in that picture before, we start to get these little depressions. That's where that oropharyngeal membrane is going to form. And then we have that cochlear membrane. That cochlear membrane is that anus and that urinary system and reproductive tracts that are forming at the tail end. So when this cochlear membrane starts to actually appear, this umbilical vesicle that forms, it forms this outpouching, atlantis, and it connects to that connecting stalk. And that gives us that formation of blood and blood vessels. Urinary bladder. Neurulation. That's that neural plate, neural folds, and neural tube that are forming. So those ectodermal cells are going to start to form that neural plate. The end of the 3rd week, we get that neural groove. It's going to fold, fuse, and give us that neural tube. That neural tube, those cells are going to give us the brain and that spinal cord. These different ectodermal cells, they're actually going to form several different layers to form a neural crest. That's our sensory neurons. Postganglionic neurons of all peripheral nerves. The adrenal glands, melanocytes, arachnoid matter, PM matter, skeletal and connective tissues. Still approximately 4 weeks. We have that neural tube that gives us that proencephalon, mesencephalon, and that rhombencephalon. 5 weeks. That proencephalon develops into that telencephalon and diencephalon. That rhombencephalon is going to turn into that metencephalon and myelencephalon. So we're starting to see this. Start with this neural plate. We go to that neural plates, neural groove, neural fold. Then you see that primitive stalk, primitive node. We're starting to see, we see that ectoderm, mesoderm, endoderm. Starting to see all of these different features starting to develop. Somites. This happens at about day 17. That mesoderm, it's kind of lateral to that notochord, neural tube is going to form columns. Paraxial mesoderm. They're going to start to form cylindrical masses, which are those intermediate mesenchyme. That mesoderm, it has a flattened pair of flattened sheets that is known as the lateral plate mesoderm. It's going to start to segment paired cube structures that are known as somites. So by that 5th week, we have 42 to 44 pairs of somites already. They develop over time and they correlate to the approximate age of the embryo. So these somates are going to develop into that dermomyotome and sclerotome. That dermomyotome gives us dermatomes. Myotome, skeletal muscles of the trunks and limbs. Those sclerotomes, vertebrae and ribs. So we can start to see these little red sections on the side here. Those are those somites. And then those somites, we get more and more of them. Here's a somite developing in here. Now we've got more somites. We start to see that dermatomal mesenchyme, the myotome, the sclerotome. Angiogenesis starts at the 3rd week to form blood vessels. That extra embryonic mesoblast is where this all starts, in that umbilical vesicle. And this is how we connect the stalk and the chorion. We need development of these vessels very early because of the yolk sac, the umbilical vesicle, and that ovum need a way to get nutrients to that embryo fast. So that angiogenesis gets initiated pretty quickly by those mesendermal cells that differentiate into hemangioblasts. That'll develop into angioblasts, which will eventually form blood islands. These spaces in these blood islands are going to form blood vessels. The angioblasts help these different tunics develop into blood vessels. These blood islands grow and fuse together. They create this extensive system of blood vessels through the embryo. Blood cells and blood plasma also start developing outside the embryo from those hemangioblasts. They start developing in the blood vessels. They're developing in the wall of the umbilical vesicle, the lanteus, and the chorion. They develop into those multipotent stem cells, and those are the ones that form those blood cells. So it begins at about the 5th week in the liver, the 12th week in the spleen, red bone marrow, and thymus. This is when blood starts developing inside that embryo. The heart. It comes from the splanopleuric mesenchyme. So in that head of the embryos, this is on days 18 and 19, that cardiogenic mesenchyme. So there's different signals, induction signals from that endoderm, and they help to form the heart primordial tubes. These tubes are going to fuse, and they form a single heart tube. So by the end of that 3rd week, this heart tube starts to bend over and in on itself. It's going to become S-shaped. It's going to begin to beat. By that end of that 3rd week, these vessels are going to start to join together. And this is going to make this primitive cardiovascular system. As these embryonic tissues are going through this uterine wall, these vessels in the uterus start to kind of erode. The mother's blood starts to fill into places. This is the tropoblastic lacunae. So by the end of the 2nd week, we have chorionic villi that'll begin to develop. Villi are these finger-like projections, and this is going to be of that chorion, and it's going to develop into that endometrial wall of the uterus. So by the end of that 3rd week, blood capillaries start to develop in that chorionic villi, and that's going to connect to that embryonic heart through those umbilical arteries and umbilical veins. And it's going to happen through that connecting stalk. So that the embryonic blood capillaries within these villi, they're going to start to go into that tropoblastic lacunae, that intervillous spaces. So these chorionic villi are going to kind of bathe in that maternal blood, and it causes this maternal blood and this chorion covered fetal blood vessels. So the maternal and the embryonic blood, technically, they never join together. The blood does not mix. We're exchanging oxygen and nutrients through this intervillous space. Developing that placenta. That chorionic villi, placentation, is that process of the placenta forming. Placenta, once that placenta is formed, that is the site where these nutrients, wastes, everything gets exchanged between the mother and the fetus. This placenta is going to produce the hormones so the pregnancy can sustain itself. It's what separates the mother and that embryo from each other, and it starts developing at about that 12th week. We have the fetal portion, and this is these layers of the chorionic villi of the chorion, and then we have the maternal portion, which is the bottom, that basal layer of that endometrium. And this is the area where we allow different nutrients to move across this membrane to exchange things out. The placenta, for the most part, is a protective barrier because these different microorganisms can't really pass through. There are viruses like AIDS, German measles, chickenpox, measles, encephalitis, and poliomyelitis that can cross through that placenta. Drugs, alcohol, some substances, that can also cross through, and it can cause birth defects. So there's different nutrients, carbohydrates, proteins, calcium, iron. These can exchange across as well, and they get released into the fetal circulation. So all of these cells that are all connected can get the nutrients that they need. So now we're starting to develop, we're seeing this connecting stalk. We have this chorionic villi, which is this area where right now we're kind of exchanging out nutrients until this placenta has fully developed. We have that umbilical vesicle coming. Here you can see that maternal sinusoid, so maternal blood is kind of collecting in here to exchange out with this fetal blood vessels here. Here we have this amniotic cavity with the embryo inside. We have this umbilical vesicle. We have these umbilical veins and umbilical arteries. We're starting to get what is going to start looking more like a developing embryo or fetus. By this point, we can see we have that amniotic cavity, that chorionic villi, umbilical vesicle. We're starting to get these umbilical arteries and veins, that amnion, they are working to exchange out different nutrients. Placenta. Now, placenta, you can see these umbilical arteries and veins, that umbilical cord, and that amnion that covers that placenta, where nutrients are being exchanged between the mother and that fetus. So that umbilical cord. The cord is the connection between that placenta and that developing embryo. Later, the fetus, by week 9 on. And this is developing from that connecting stalk. It's about 1 inch wide. It can be 20 to 24 inches long by the time it is finally fully developed. It has 2 umbilical arteries, and that carries deoxygenated fetal blood to the placenta. 1 umbilical vein that carries that oxygenated blood and nutrients from the mother's intervillous space. There's mucoid connective tissues. We have that amnion that surrounds the entire umbilical cord. This umbilical vein can sometimes be used to transfuse blood into a fetus. It can be used to induce drugs for different medical treatments. 1 in 200 newborns only has 1 umbilical artery. And when that happens, 20% of these that have only 1 umbilical artery tend to develop different cardiovascular defects. So after birth, that placenta will detach from the uterus. The umbilical cord gets tied off and cut, and it usually remains attached to that baby for 12 to 15 days before it eventually will fall off. There are several pharmaceutical companies that actually use placentas for hormones, for different drugs, blood, like burns. They can use parts of or from the placenta for vessel grafts. Cord blood can be frozen for these pluripotent stem cells if something were to ever happen. Both my niece and nephew, their umbilical cord was frozen for any potential future use. So it's a really cool thing that you can do now, so you can have access to these stem cells down the road if something were to ever happen. Sometimes the entire or part of this placenta, it can become implanted into the lower part, that inferior uterus. This is known as placenta previa. It can cover that internal os of the cervix. It can lead to a spontaneous abortion, but it also happens in 1 in 250 live births. It's dangerous because it can cause premature birth, intrauterine hypoxia because of maternal bleeding, can cause mortality of the mother because of hemorrhaging and infection. It's usually painless, but you get bright red vaginal bleeding in that 3rd trimester when that fetus just grows so rapidly. They usually have to do some sort of C-section, cesarean section, because if the placenta is blocking the vaginal canal for that fetus to leave, it can't get out. So they have to go in and physically get that baby out through a cesarean section. So during this 4th to 8 weeks of development, this is the fetal develop, or the embryonic development still. We still have our embryonic development happening. This is when organogenesis happens. Organs, making, genesis means we're building or making, we're making organs. So by the end of the 8th week, all of our body systems have started to develop. They don't function very well yet, but they're developing. So they've got their blood vessels, so they get their oxygens and their nutrients. So at that 4th week too, this embryo starts to go through changes in shapes and size. It's going to about triple its size at this point. It goes from that 2D flat trilaminar disc to this 3D embryonic folding. It has that endoderm center, that gut, that ectoderm, that epidermis, and that mesoderm between. We get that head fold, that tail fold. We have these horizontal planes that give us those lateral folds. And they all create this C shape. The head brings that developing heart and mouth into their adult positions. That tail end, that fold develops into the anus. The lateral folds start to bend ventrally towards the front. They're going to kind of incorporate with that dorsal part of the umbilical vesicle as that primitive gut starts to develop. That primitive gut is going to differentiate into the foregut, midgut, and hindgut. The oropharyngeal membrane at that head is going to give way for that pharyngeal region of that foregut. That'll be that oral cavity. The head folding gives us that oropharyngeal membrane, and the foregut stomatum, we're going to start moving to their final positions. This is all happening during this 4th week. The oropharyngeal membrane ruptures. So that pharyngeal region of the pharynx starts to be brought in contact with that stomatum. So that hindgut, that's what gives us that cochlea, that uroanal and reproductive. So that tail region, we start with that proctodeum, that cochleal membrane. It's going to divide into that urogenital sinus, that anorectal sinus, anorectal canal, proctoduum, and they're all going to go into their final position. So that cochleal membrane ruptures at that 7th week. So that urogenital and anal openings are created when this cochleal membrane ruptures. Those somites develop the neural tube. There's 4 pairs that give those pharyngeal arches. That's at that future head and neck. We have 4 paired structures that develop on day 22 and form these swellings on that surface. So these are those pharyngeal arches that are those somites that differentiate into those pharyngeal arches that are being developed here. Each of these pharyngeal arches has their own artery, cranial nerve, cartilaginous skeleton rods, and then the skeletal muscle tissue that's going to attach the cartilage. That is all connected together. So this ectodermal surface, these pharyngeal arches, is separated by this pharyngeal groove, which will differentiate into pharyngeal pouches. These somites are going to give us different structures, that pharyngeal arch, groove, and pouch. Each of these arches is going to have its skeletal component, the muscle, the nerve, and the blood vessels for that specific area. Those otic placodes from the ear starts at day 22. Those lens placodes also starts appearing by day 22. So by the middle of that 4th week, we start to see upper limbs begin to develop, these upper limb buds. We also see lower limb buds. So our arms and our legs start to develop. The heart forms this distinct projection on that embryo surface that gives that heart prominence. There's also a distinctive tail by the end of the 4th week. So we can see as all of this is happening, we can start to see everything start to develop, that neural tube, notochord. We get that oropharyngeal membrane. Now we can see more of that neural tube, notochord. These lateral folds start to come down. You can see as everything starts to move through, we get this heart starting to come, this head fold, this tail fold. So you can see how we get this head and this tail coming through. We can see these pharyngeal arches, that lens placode, that otic placode, that heart prominence, these pharyngeal grooves. But you're going to further go, we have the brain starting to develop, we have the thyroid, the heart is starting to develop even further, these pharyngeal arches, these pharyngeal pouches, we have the esophagus starting to come. We can see all of these different pharyngeal arches. Everything starting, the cartilage, the nerves, the muscles. These are all being created. This is about day 28 already. So during the 5th week of development, that brain is going to develop very rapidly, causing the head to start to grow. End of the 6th week, that head gets even larger. Those limbs start developing. That neck and that trunk begin to straighten out. The heart now has 4 chambers to it. The 7th week, these limbs have become more distinct. We start to see digits appear. So at the start of that 8th week, the digits are webbed. We still have a tail. The eyes tend to be open. The auricles of the ears are starting to be visible. So by the end of the 8th week, all parts of the limbs, the digits are no longer webbed by that 8th week even. The eyelids actually come together. That tail disappears. And this is when the external genitals start to differentiate. Now we've reached the fetal period. This is from week 9 on. Those tissues in that all of those organs, they continue to grow and differentiate. We don't get very many new structures during the fetal period, but that body growth is very fast. That second half of that intrauterine life, that fetus is growing very, very, very fast. So at the beginning of this fetal period, the head is half the length of the body. By the end, it's only a quarter of the size of the body. The fetus is less vulnerable to drugs, radiation, and microbes during this fetal period. So here we can see day 22, what we have at day 24. By day 32, 44, 52, You can see 10 weeks, 13 weeks, 26 weeks. You can see how this is differentiating from a embryo to a bunch of cells, from a bunch of cells to an embryo to a fetus. So these charts are nice. They go through the main things that happen during these different stages, these different parts of fetal periods, the size and weight approximately, average. And this chart shows from 4 weeks to 36 weeks what this growing embryo and fetus are looking like. Fetal surgery. They do fetal surgery from time to time, and it's usually if there's some sort of life-threatening congenital disease. So they try to correct it before it advances too far before birth. It can be performed when this fetus otherwise won't survive, isn't expected to survive. Or if they do make it outside of the womb, they don't live long enough after birth to survive surgery. There's open fetal surgery. So they make an incision in that lower abdomen, expose the uterus, open it. That fetus is partially removed and then returned. Fetoscopic, they make little tiny incisions. And they use these little tools where they send down cameras and tools and do the surgery, but that fetus still inside that uterus. It can correct hydrocephalus. It can clear the urinary tract and tracheal obstructions, repair heart damage, organ defects, pulmonary cysts and tumors. That could be found at the base of that backbone. Spina bifida. Spina bifida is where those lamina on those spinous processes fail to develop, so that whole spinous process fails to develop. Pterogens. So exposure to different environmental factors can damage or even cause death to a developing fetus or embryo. So a pterogen specifically is an agent or an influence that can cause developmental defects in this embryo, like fetal alcohol syndrome. This is the #1 fetal teratogen. It is the most common cause of mental retardation. And it is the most common preventable cause of birth defects. There's slow growth before and after birth. There's facial features to a child of fetal alcohol syndrome, defective heart, other organs. The limbs may not form completely. The genitals may not be abnormally grown. There could be damage to the central nervous system. These children are hyperactive, extremely nervous. They're hyperactive. They're not able to concentrate very well. They can't appreciate those cause and effect. Viruses like hepatitis B or C, papilloma viruses, pesticides, defoliants, industrial chemicals, hormones, antibiotics, oral anticoagulants, anticonvulsants, anti-tumor agents, thyroid drugs, thalidomide, and there's a lot of others, prescription drugs, LSD and cocaine. So a pregnant woman who uses cocaine actually can cause a retarded growth in that fetus. Attention and orientation problems, hyperirritability. They have a tendency to stop breathing. They can be malformed. They can have missing organs. There's also risks of spontaneous abortions, premature births, and stillbirths by a lot of these different medications, viruses, alcohol, different substances, different things that are in the air and the world around you. There's a lot that affects this fetus. This is why as soon as people know they're born, there's a lot of restrictions on what they can and cannot have, medication-wise, drink-wise. Another one, cigarette smoking can cause low birth rate. Can cause fetal and infant mortality. There's a much higher risk of that ectopic pregnancy. Can cause cardiac abnormalities, anencephaly, cleft palate or lip, SIDS, sudden infant death syndrome. If that mother is smoking while nursing, it can cause digestive canal problems. Secondhand smoke during pregnancy or nursing can increase the risk of respiratory problems, bronchitis, pneumonia in that first year of life, asthma. My father used to smoke while my mother was pregnant with me. I had really, really severe asthma most of my childhood into my early adult life because of this. Irradiation, which is this ionizing radiation. X-rays, radioactive isotopes. During that embryonic life, it can cause microcephaly, a small head, mental retardation, skeletal malformations. This is why all women, when they go to get any kind of imaging, the question, even though it's on the paperwork, they ask you verbally, are you pregnant? Any chance of being pregnant? Because they're trying to prevent any of these from happening. So there's different tests that can be done, prenatal diagnostic tests. Sometimes these are done in older women when they're pregnant. Just because the older you are, there's more chances of different birth defects when you have children. Just happens to be that way. So some of these, they do some of these tests on everybody. They do some of these tests on specific populations, just depending on what this person has been around, what kind of family history they have even. So that ultrasonography, this they do on everybody because it's the most common way. It is the most accurate way we can, or more accurate way we can get that fetal age, because there's certain landmarks, because we went through what happens the beginning of this week, the end of this week, like 12th week, since everything develops very much in a specific pattern, they can tell how old this embryo or fetus is. They can confirm that pregnancy even through ultrasound. They look at fetal position, that growth, viability, making sure that fetus can survive outside of that womb. There's multiple pregnancies. Fetal maternal abnormalities. So they use these sound waves. Ultrasound is using these sound waves. These sound waves bounce back to this transducer that is reading it, and that is giving us a sonogram. There's amniocentesis. This is one that they like to do on older pregnant women. They take some of that amniotic fluid and they look at the fetal cells that are found in that amniotic fluid and the different substances. because they can check for different genetic disorders like Down syndrome. Down syndrome tends to be more common the older you are when you get pregnant. Hemophilia, Tay-Sachs disease, sickle cell disease, and different muscular dystrophies can actually be determined through amniocentesis. They can help the survivability of that fetus, especially if they have any of these diagnoses above. They do it between 14 and 18 weeks. So they can look at chromosomal abnormalities, biochemical defects. It can even reveal the baby's gender or different sex-linked disorders. Chorionic villi sampling, CVI. It can detect the same defects as amniocentesis. They send up a catheter through the vagina, through the cervix, into that uterus, and they pull some of this chorionic villi. It can be performed as early as 8 weeks. It's more risky because it can cause a spontaneous abortion. There's non-invasive prenatal tests. These are more safe. They're a lot safer. They're more accurate, and they're more efficient tests. So right now, this chorionic villi and the amniocentesis, they're useful to look at the fetal tissue, but they're trying to develop more and more of these non-invasive prenatal tests. One of these that they have come up with is the maternal alpha fetal protein test. So they take the mother's blood and they look for this alpha fetal protein. It's 95% accurate because at highest level is at weeks 12 to 15. So if there's a high level after the week 16, that fetus will have neural tube defects, spina bifida or ancephaly. There is also quad alpha fetal protein plus, which is a newer test. This can screen for Down syndrome, trisomy 18, neural tube defects, and it can even predict a delivery date. It can even reveal the presence of twins. So home pregnancy tests. They can be taken during the first 3 to 4 months of pregnancy. That corpus luteum, it's secreting progesterone and estrogens. These progesterone and estrogens are used to maintain the lining of that uterus. It prepares those mammary glands to secrete out milk. So that corpus luteum only provides just a little bit more than what is produced after ovulation. So from that 3rd month on, the placenta is what gives those progestrogens and estrogens. That placenta gives us that human chorionic gonadotropin. It gets excreted out through the urine. This human chorionic gonadotropin, it can be found in the blood, and it stimulates that corpus luteum to continue to produce progesterone and estrogens. So 8 days after fertilization, that HCG can already be detected in the blood and urine. And you can detect it till about 9 weeks. Through 9 weeks or so. So that 4th or 5th month, those HCG levels start to fall off. So they still are there. They're just not as high as they were during the beginning phases. So these hormone pregnancy tests. So that chorion is secreting estrogens after that 3rd and 4th week. Progesterone by that 6th week. And they continue to secrete it. So by that 4th month, when that placenta is developed completely, it secretes out that HCG, but it starts to reduce it. The corpus luteum isn't needed anymore. So those progesterones are making sure that myometrium remains relaxed, that cervix remains closed. The hormone relaxin was produced by the corpus luteum. It starts to get produced by that placenta. It does increase the flexibility of that pubic symphysis and the ligaments of the sacroiliac and the sacrococcygeal joints. It'll help to dilate the cervix. Human chorionic somatomammotropin, HCS. This is another hormone that comes from the placenta, and it increases the rate of secretion of that placental mass. And it kind of reaches its maximum secretion after 32 weeks. We think it helps those mammary glands get ready for lactation. Enhances maternal growth by increasing protein synthesis, and it regulates parts of that metabolism for the mother and the fetus. There's also corticotropin releasing hormone. It's produced by the placenta. In non-pregnant people, it is secreted by the hypothalamus. It's part of the clock that is going to establish the timing of birth. It starts at 12 weeks and it increases until the end of pregnancy. So women who have higher levels of this corticotropin releasing hormone earlier in their pregnancy are more likely to deliver prematurely. Those with lower levels tend to deliver after their due date. So these increases in these secretions of cortisol are actually needed for those fetal lungs to mature and that surfactant to start to get produced for that baby to be able to inflate and keep their lungs inflated. So there's different changes that are happening to the mother during this pregnancy. So at the end of that 3rd month, the uterus takes up most of that pelvic cavity. That fetus is continuing to grow. The uterus continues to expand up higher into that abdominal cavity. It reaches all the way up to the ribs, that costal margin. So all of those maternal organs get pushed up, elevating that diaphragm up. It widens that thoracic cavity even. This is what causes heartburn and that need to urinate constantly, as that uterus sits right on top of the bladder. That stomach is being pushed up so high that it can cause any contents to end up going back up that esophagus, giving that heartburn. So early pregnancy tests, they can actually start to detect about 8 days after fertilization because that HCG is high enough. It's in the urine. Most early home pregnancy tests are urine tests. It's being secreted at about 8 days. So technically 2 weeks. So that first day of a missed menstrual period after fertilization, these home tests can truly detect it. 8 days is when that HCG is starting to be secreted. There's a lot of different tests out there. Some are very sensitive and accurate. The most sensitive and accurate, go to hospital, most of these tests are getting more and more sensitive and accurate they're pretty reliable at home, but there's still false negatives and false positives. False negatives, you're testing too soon, or there's an ectopic pregnancy. A false positive could be too much protein in the blood, or protein or blood in the urine, or HCG could be produced because of a uterine cancer. Diuretics, hormones, steroids, thyroid drugs, these can all affect early pregnancy tests. So pregnancy causes weight gain, increased storage of proteins, triglycerides, minerals. The breasts enlarge as they get ready for lactation. It causes lower back pain as that belly gets larger and larger, causing this lordosis. The mother has several cardiovascular changes. Their stroke volume increases. Their cardiac output increases. Their heart rate, resting heart rate increases, and the volume of blood even increases, especially during the second half of that pregnancy, because they're trying to meet the demands of that fetus for all of the oxygen and nutrients that they need. So when a pregnant woman lays on their back, especially later in the pregnancy, it could possibly compress that abdominal aorta, and that decreases blood flow to the urine. They can or the uterus, sorry. They can compress that inferior vena cava. That venous return goes down, causes edema. Compression of the renal arteries can lead to renal hypertension just by laying on their back, compressing all of the blood vessels and everything back there. Their tidal volume, respiratory, increases. That expiratory reserve goes down because everything's getting pushed up into your rib cage. That functional residual capacity decreases. The minute ventilation can increase. Airway resistance goes down. Oxygen consumption will increase. Dyspnea occurs. That you have an increased appetite because you're feeding yourself and that developing child. But you get decreased digestive canal motility, which can cause constipation, delaying gastric emptying, nausea, vomiting, and heartburn. And that urinary system, since that uterus sits right on top of it, it can cause urinary symptoms like frequency, urgency, stress, incontinence. Increase in renal plasma, increased glomerular filtration rate. Your skin. Some women may get increased pigmentation around their eyes and cheekbones. The areola of the breasts, and then that linea nigra down the middle of the stomach. Striae or stretch marks can occur. Tearing of that connective tissue layers, that dermis that forms scar tissue. Hair loss. That genital system can start to collect edema. They get increased vascularity to the vulva. So 10 to 15% of women in the US experience pregnancy-induced hypertension. So they get that elevated blood pressure. Preeclampsia is the major cause. Preeclampsia is where there is a sudden hypertension, large amounts of proteins in the urine, and edema. It's usually after the 20th week, not month, of pregnancy. So they have edema, blurred vision, headaches. It can be related to autoimmune or allergic reactions, bad rest, and there's some drugs. And it's associated with eclampsia, convulsions, and coma. There's only a few changes in the ability to be able to exercise during pregnancy in the beginning, but you get tired a lot easier, especially in the beginning. Morning sickness. So as this pregnancy continues to progress, weight starts to get gained more. It requires more energy to do something. It can put more weight into certain joints, like that pubic symphysis starts to become less stable because of that relaxin. By the end, mothers may walk with a widespread legs and a shuffling motion. The heat that gets generated during exercise can cause dehydration a lot faster. It can increase your body temperature a lot quicker. So excessive exercise in early pregnancy, this heat starts to build up. It should be avoided because elevating the body temperature can cause neural tube defects. But moderate physical activity does not cause problems to the developing fetus. Labor. Labor is the process where this fetus is expelled from the uterus through the vagina. The onset of labor is set off by several different hormones. Progesterone is what inhibits those uterine contractions from happening. So progesterone levels need to go down first. So at the end of gestation, the time that fetus is in that uterus, estrogens start to rise. And it starts to inhibit the effects of progesterone. The placenta is releasing that corticotropin releasing hormone, which is going to stimulate that anterior pituitary gland to secrete adrenocorticotropic hormone. The fetal adrenal glands, cortisol and dihydroepiandrosterone, DHEA, and the placenta takes that DHEA and converts it into more estrogens. This is what's giving us all that estrogen. It causes the receptors for oxytocin on the uterine muscle fibers to increase. So these muscle fibers start forming gaps. Gap junctions. This oxytocin starts to get released from that posterior pituitary. Oxytocin is what stimulates that uterine contractions, that relaxin that has been released throughout that pregnancy, increases the flexibility of the pubic symphysis, and it helps that cervix dilate a lot easier. Prostaglandins are being released by that placenta. These prostaglandins produce enzymes that are going to digest the collagen fibers in that cervix. This is what helps it soften so it can expand. Labor is a positive feedback. So as contractions of that uterus, it forces that baby's head and body into the cervix. As that cervix stretches, distending, those stretch receptors sends up information to that hypothalamus, causing that hypothalamus to release more oxytocin. As more oxytocin comes out, it stimulates more contractions on that myometrium, that uterus. These contractions continue to intensify as more and more oxytocin get released. With the birth of that infant, this positive feedback cycle gets broken down. That stretching of that cervix is no longer happening. These uterine contractions occur in waves. So they start at the top of the uterus and they move down to help try to expel that fetus out. We have true labor, and this is when these uterine contractions occur at regular intervals. They do produce pain and they're easy to time because you're looking for more regular intervals. You can time between each contraction. So as these intervals shorten, the contractions get stronger and stronger. So the best way to determine true labor is that dilation of that cervix and that show. That show is that head peeking out and that discharge of blood containing mucus in that cervical canal. False labor, pain is felt at irregular intervals. It does not intensify, and walking doesn't alter. There's no show and there's no dilation. So we have 3 stages of this true labor. Stage of dilation, it's 6 to 12 hours. And this is from that onset of labor till that cervix is dilated to 10 centimeters. That stage of expulsion, it can last 10 minutes, it can last several hours. It is from that complete cervical dilation to that delivery. The placental phase can be 3 to 5 minutes or up to an hour or even longer. This is delivery of the placenta. That placenta or afterbirth needs to be expelled. So uterine contractions are still working to get rid of that placenta after that baby has been born. Helps to constrict blood vessels that were torn during delivery because we're trying to reduce the chances of hemorrhage. With the first baby, labor tends to last longer. It typically averages about 14 hours. For multiparous women who've given birth more than once, multiple, labor is usually about 8 hours. About 7% of women do not deliver by 2 weeks after their due date. This causes an increased risk of brain damage and fetal death because that placenta starts to age. Most babies aren't allowed to be carried more than a week past their due date anymore. I was 3 weeks late. They tried to induce and they ended up having to do a C-section to get me out. I liked it in there. It was nice and cozy. But nowadays, they don't allow babies to go 3 weeks, let alone they usually don't even let them go 2 weeks anymore. They use Pitocin or oxytocin to try to cause these uterine contractions to start to happen, to start this labor process. If that doesn't work, surgical delivery, a C-section may occur. So following delivery of that baby and the placenta, there's a 6-week period after this. These maternal reproductive organs and physiology are going to return to this pre-pregnancy state, peripuerium. Tissues go through catabolism. The uterus reduces in size, involation. The cervix is going to lose its elasticity again. So it gets this pre-pregnancy firmness. 2 to 4 weeks after delivery, women tend to have a discharge from the uterus. Lochia. It's usually some blood, and then there's some serous fluid, and it's coming from where that placenta was once attached. Dystocia, difficult labor. It could be because of that fetus being in an abnormal position or that birth canal being too small. A breached presentation, that is where that fetal buttocks or legs are at that cervix instead of the head entering first. This can happen in premature babies. It's more common to see. If fetal or maternal distress prevents a vaginal birth, that is where they'll do that cesarean section, C-section. So this infant has been born. There has to be some respiratory adjustments here because that fetus originally depended entirely on their mother for oxygen and getting rid of carbon dioxide. Those lungs were filled with amniotic fluid and still partially collapsed down. So they start producing surfactant at about the end of the 6th month. That respiratory system is pretty well developed. So babies that are delivered at 7 months, they're able to breathe and cry even. So after delivery, the amniotic fluid in the lungs starts to be absorbed. Because that mother is no longer removing that carbon dioxide, it starts to build up. This is what stimulates the respiratory center in the medulla to cause those respiratory muscles to contract. That is where the baby will draw their first breath. That first inspiration is very, very deep. It's an unusually deep breath because the lungs don't have any air yet. So then that baby starts to exhale vigorously, and this is what causes them to start crying. A full-term baby can breathe 45 times per minute for those first 2 weeks, and then it'll gradually decline over time. Cardiovascular system. So that cardiovascular system has to make several adjustments. That foramen ovale, that opening between the right and the left atria, it closes shortly after birth. So it takes that deoxygenated blood to the lungs for the first time. So those lungs start to function. That ductus arteriosus between the aorta and the pulmonary trunk closes off. That becomes a ligamentum arteriosum. So this is because of this polypeptide, this bradykinin that's coming from the lungs as those lungs initially inflate for the very first time. So the closing of that ductus arteriosus, that foramen ovale, 12 to 24 hours after birth, and it's completed by 21 days after birth. A patent ductus arteriosus is where it doesn't close, that ductus arteriosus. So after the umbilical cord is tied off, cut off, blood no longer flows through these different umbilical arteries anymore. They start to fill with connective tissue. They become the medial umbilical ligaments. The umbilical vein becomes ligamentum teres of the liver. An infant's pulse rate can be anywhere from 120 to 160 beats per minute, as high as 180 when they're excited. Oxygen they start to increase that use of oxygen, and they increase the rate of red blood cell and hemoglobin production. White blood cell count is usually very high at the very beginning, but then it slowly starts to decrease down. Premature babies, or premature infants. They generally weigh less than 5.5 pounds at birth. Delivery can cause certain risks, and sometimes it could be because they could be delivered premature because of poor prenatal care, drug abuse. If you've had a previous premature delivery, you may have another one if the mother's age is below 16 or above 35. Being pregnant above the age of 35 is called a geriatric pregnancy. It's a lovely name, but it's just, and it makes you more high risk from the start. Premature infants, they're not ready to sustain life outside of that womb 100% yet. So a lot of times medical intervention is needed. So if they're delivered under 36 weeks, usually they have respiratory distress syndrome, and that's because there's not enough surfactant. There is artificial surfactant, and then they can use ventilators to help deliver oxygen to those lungs until they can fully develop or function on their own. Lactation. That is the production and ejaculation or ejection of milk from the mammary glands. That hormone, prolactin, from that anterior pituitary gland is what causes that lactation to start to happen. These levels start to increase as that pregnancy starts to progress. But milk doesn't start being produced because progesterone is going to inhibit that. So after delivery, estrogen and progesterone levels start to decrease. It releases that inhibition, causing that prolactin to allow the secretion and that lactation to actually happen. The sucking action of that infant also helps to stimulate lactation to occur. Because there's these nerves from these stretch receptors in the nipple that go to this hypothalamus, and it decreases prolactin inhibiting hormone, and it's going to increase prolactin releasing hormone. So more of this prolactin gets released out. Oxytocin can also cause milk to be released. It gets milk released from the mammary ducts through mammary or milk ejection reflex. So milk gets formed in these glandular alveoli of the breasts. And it's stored there until that baby starts suckling. So stimulation of different touch receptors at the nipple is going to initiate impulses that go to the hypothalamus, which will allow that oxytocin to start increasing. This oxytocin causes the contraction of these epithelial cells, myoepithelial cells, and that's what causes this milk to be ejected out. It takes 30 to 60 seconds after nursing begins for milk to finally start to be ejected out of the breast. Late in pregnancy, in those first few days after birth, the breast is only going, these mammary glands are secreting this substance that is called colostrum. It is not milk, not as nutritious. Doesn't have as much lactose. There's no fat to it, but it can adequately nourish that new baby until that milk truly comes at day 4. It does contain antibodies, so it protects that infant during those first few months of their fetal life. So following birth, prolactin will start to return to its non-pregnant levels. Nursing mothers, every time those nipples get stimulated through that suckling, it'll cause prolactin to be released, and that prolactin being released lasts about an hour. So it kind of acts on those mammary glands to provide milk for the next nursing period, because those mammary glands are already storing milk for the current nursing period. So if that prolactin surge is blocked because of some injury, nursing is discontinued, the mammary glands will lose their ability to produce milk in only a few days. Doesn't take long. So milk already starts to decline within that 7 to 9 months after birth, but it can continue for several years if breastfeeding continues. Nursing tends to block the ovarian cycles, especially for the first cycle following delivery, if that frequency of suckling is 8 to 10 times a day. So ovulation usually precedes that first menstrual period after delivery of a baby. So mothers can never be certain if they're fertile or not while they're breastfeeding, especially those first months. So breastfeeding is an unreliable birth control measure. So that physiology. So the benefit of breastfeeding is that human milk is more sterile of a solution. It has fatty acids, lactose, amino acids, minerals, vitamins, and water that are what the baby needs for digestion, brain development, and growth. So we have these beneficial cells, white blood cells, that are present in breast milk. There's neutrophils and macrophages that are those phagocytes. They help to ingest different microbes that may be in that baby's digestive canal. Those plasmacytes, they get antibodies against any microbes. We have beneficial molecules. So these different antibodies, IgA for binding to these different microbes, that's going to help prevent this migration of these microbes to other tissues. So when the mother produces antibodies to whatever disease-causing microbes that are present in her environment, it goes into her breast milk. So it's going to offer protection against those microbes to her baby. Breastfeeding has been shown to decrease the incidence of disease later in life. So it provides children with a slight reduction in lymphoma, heart disease, allergies, respiratory and digestive canal infections, ear infections, diarrhea, diabetes, and meningitis. It supports optimal infant growth. It enhances intellectual and neurological development, mother-infant relations. It has more digestible fats, iron, proteins, lower sodium than whole milk. Premature infants can benefit even more because at higher proteins. So inheritance. About 20 slides here on inheritance. Inheritance is that passing of different traits from one generation to the next. So it's things that you are going to, different characteristics you get from your parents. And what you would pass down, would possibly pass down to your children someday, if you choose to have them. So all human cells, except for these gametes, have 23 pairs of chromosomes, one from their mother, one from their father. Each of these homologues contains genes that are known as alleles. So a mutation is a permanent inheritable change in this allele. It's going to produce different variants of this trait. So the relationship of genes to hereditary is looked by examining alleles that are involved in some of these disorders. Phenylketonuria, people with this phenylketonuria or PKU, they do not manufacture this enzyme, phenylalanine hydroxylase. Punnett squares can show the possibility of getting some of these different genetic mutations. So they take paternal alleles on one side, maternal alleles from the ova and the other. So they're 4 squares, and these 4 squares are going to produce 3 different combinations of genes known as genotypes. People who have the 2 capital letters or a capital letter, lowercase letter for phenylketonuria, they don't get phenylketonuria. They need the 2 lowercase letters. This is recessive on both ends to get phenylketonuria. So here's how it works out. So we have father has fetal, one capital, one lowercase. Mom has one capital, one lowercase. So they carry it, but they don't show it. They carry it, but they don't show it. So they match up. These 2 boxes here match up to give us 2 capital P's. This box to this box gives us 1 capital, 1 lower. This box to this box gives us 1 capital, 1 lower. This one to this one gives us 2 lower. This is a recessive gene. If you have 2 recessive genes, you show this PKU. So this is everything that I stated above. The phenotype. That is how this genetic makeup gets expressed. So the physical or outward expressions of genes. So heterozygous individuals, they carry the capital lowercase. They are carriers. Those lowercase letters makes them carriers. So most of these genes are going to give rise to the same phenotype, whether they are inherited from the mother or the father. So in some cases, the phenotype is dramatically different. This is genomic imprinting. So these abnormalities are associated with the mutation, so they're of the gene they are imprinted on. Angelman syndrome, this is mental retardation, ataxia, seizures, and minimal speech. And it's because of the gene for the particular abnormal trait that is inherited from the mother. Prader-Willi syndrome, short stature, mental retardation, obesity, poor responsiveness, sexual immaturity. This one is inherited from the father. So non-disjunction. This is where we get an error in cell division. So we end up with an abnormal number of chromosomes. So during that homologous chromosomes during meiosis 1, or sister chromatids, or mitosis or meiosis 2, they fail to separate correctly. Let's see if there was a picture of that. Aneuploids or cells where they have one or more chromosomes that have been added or deleted. Monosomic cells are missing chromosome. Trisomic cells have an extra chromosome. Down syndrome, they usually have trisomic cells of that chromosome 21 specifically. So they have an extra 21st chromosome. Translocation is an error in meiosis. So these two chromosomes that are not homologous, they're not the same, they break and they kind of interchange different areas. So during this translocation, we have these different chromosomes. I'm going to draw them in different colors here that are an area. Now that I did that, I need to make them larger. So this area and this area are going to switch with each other. That's what this is talking about. So in some people's gametes, this happens. So about 3% of Down syndrome cases, this is because of some sort of translocation error in part of that chromosome 21 to another chromosome, like 14 or 15. So these are different recessive traits and dominant traits. So both parents have to pass you the recessive gene to get these different recessive traits here. Normal vision is a recessive trait. So both parents have to pass you that recessive gene to get it. Here's the interesting one. Polydactyla. Polydactyly. Extra digits. Short digits. These are all dominant. Widow's peak versus a straight hairline. Hypercholesterolemia is on the dominant gene, while normal cholesterol levels are on the recessive genes. So most patterns of inheritance, they don't always conform to this dominant recessive idea. There's different phenotypic expressions that can influence, they get influenced by what some of the alleles are present, but they also get influenced by the other genes and the environment. So many of these different inherited traits, they tend to be on more than one gene. So most genes can influence more than one trait. Hair color, eye color. So incomplete dominance. So neither parent of this pair of alleles is dominant over the other. So the heterozygote has the phenotype in between the homozygous dominant and the homozygous recessive phenotypes. That gives people sickle cell. So that hemoglobin we have the possible sperm, we have the possible ova. And this bottom box is these people who would have sickle cell. These other two boxes here are carriers. This box, they are neither a carrier nor do they have the trait. So multiple allele and inheritance. So it's somebody who inherits two alleles for each gene. So some genes may have more than one alternative form. That is that multiple allele inheritance, that more than one, like that ABO blood group. So we can see all of the different outcomes. A could give A or O. A and B could give AB, 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 or O. So it's kind of interesting. O and O can only give O. But it's kind of interesting how some of these blood types can come out with O and all you see is, and that's because of these multiple allele inheritance. Complex inheritance, which is where we are inheriting traits that are not controlled by one gene. They are instead controlled a combined effect, polygenic inheritance, or the combined effect of many genes and the environment. That's a complex inheritance. Skin color, hair color, eye color, height, metabolism rate, and your body stature, your build. So one genotype can have many possible phenotypes, and it's going to depend on that environment. Or one phenotype can include many possible genotypes. So even though somebody may inherit the gene to be tall, their full height they may not reach their full height just because of the environment they grew up in. A pregnant woman who lacks folic acid in their diet, it usually can lead to neural tube defects. This is why some of these most of our foods are now infused with folic acid to prevent folic acid or neural tube defects. So under a microscope, those 46 chromosomes in the normal cell can be identified by their size, shape, staining pattern, and be members of 23 different pairs. These different chromosomes, they're arranged in decreasing order of size, and according to their position of the centromere, that karyotype. 22 of the pairs, this homologous chromosome, they look alike. They have the same appearance. Those are those autosomes. That 23rd is that sex chromosome, so that XX or that XY. So when sperm go through meiosis, they produce two sperm. One will contain that X chromosome, and one will contain that Y chromosome. So both of these male and female embryos, they develop identically until 7 weeks. After that 7 weeks, one of these different genes is going to start the cascade of motion into developing of a male, or if that absence of that gene, a female. So here's all of these 23 different chromosomes. You can see number 1, 2, how they start really large, they get smaller and smaller until we get to those sex chromosomes, so the X and that Y. The X is the large one, the Y is the small one. And we can see on a Punnett square how we get females and males. Color blindness. This is the sex-linked inherited disease. It is Red-green is the most common. So they're either missing the red or the green sensitive cones. So red and green are seen as the same color. Females can be carriers, but it's very rare to see a female with color blindness. It does happen, but it's not as common. They have to get that recessive gene from both parents. Males, it's more common to see it because of that Y chromosome. That mother was a carrier, that Y chromosome doesn't have that color blindness allele or phenotype or genotype, sorry, one of the three genotypes on it, which makes it more common in males. Hemophilia. This is where people fail to clot their blood or clots extremely slowly. It is a recessive gene. Fragile X syndrome. I've worked with kids with Fragile X in the past. It's very interesting. It is another one of these syndromes. Fragile X syndrome is a lot like autism, but it's a genetic trait that's causing it. Other ones, non-functional sweat glands, certain forms of diabetes, deafness. I like this one, uncontrollable rolling of the eyes can actually be a recessive type of, it's a sex-linked trait. Those incisors are missing, night blindness, cataracts, juvenile glaucoma, muscular dystrophy. These are all sex-linked diseases. So females, since they have two X chromosomes in every single cell, they have two sets of these genes for this X chromosome. So one of these X chromosomes gets inactivated. So it reduces the X chromosome gene to a single set in females. So one of these X chromosomes is randomly and permanently inactivated during development. The inactivated X chromosomes are not expressed. That is known as the bar body. So during this inactivation, there's different chemical groups that are going to present this transcription into RNA. So they get added to this X chromosome's DNA. Female infertility. Female infertility is that inability to conceive. It's going to occur in about 10% of women of reproductive age specifically. Ovarian disease is one of the more common causes. Obstruction to the uterine tubes, where the uterus is not adequately prepared for fertilization. Male infertility. This happens in about 10% of males. And it's that inability to fertilize that secondary oocyte. This does not imply erectile dysfunction. It requires production of adequate quantities of normal sperm, unobstructed transport, and being able to deposit it into the vagina. These are all things that are actually looked at to determine male infertility. Females, inadequate amounts of body fat. Because females have to have a certain amount of body fat to be able to conceive and maintain a pregnancy. On the other end, morbidly obese women, they can also experience problems. They can have amenorrhea and they can also have infertility. Males can have experienced genital problems because of undernutrition and weight loss. So most fertility techniques use a lot of different techniques. We have in vitro fertilization. This is where fertilization happens in a dish. So mother is given large levels of hormones soon after this menstruation, so that there's several secondary oocytes that get released. This is a super ovulation. They go in and harvest those. All of these follicles are harvested. They're put into a petri dish where they're transferred with a solution that contains sperm, where the oocyte can go through fertilization. Embryo transfer. So a man's semen is used to inseminate a secondary oocyte donor. So after fertilization, that donor's uterine tubes, the morella, the blastocyst, gets transferred to the donor of the infertile woman, and then it is carried to term. It can be used for women who are infertile, do not want to pass their own genes because of some sort of genetic disorder. Gamete intrafallopian transfer. This is to mimic more normal fertilization. So, but it's an attempt to pass the conditions of that female genital tract and hoping to, these conditions may actually prevent that fertilization though. So there's a lot of abnormalities that can be present at birth, and they're usually some sort of congenital defects. And it's going to occur during the formation of different structures, so that 4th to 8th week of development. These different stem cells establish the organ development. So structural defects can occur in about 2 to 3% of live infants, and they're the leading cause of infant mortality. So 21% of infant deaths are because of structural defects. They can be prevented by different supplementation, avoidance of different substances like neural tubes, spina bifida, ancephaly, by getting folic acid supplementation into that mother. Down syndrome, where they have 3 copies of that chromosome 21. 1 in 900 infants is born with Down syndrome. Older women are more likely to have a baby with Down syndrome. Under 30, it's 1 in 3,000. 35 to 39, it's 1 in 300. 48, by the age of 48, it's 1 in 9 babies have Down syndrome. That mental retardation, retarded physical development. They have very distinctive facial features, kidney defects, suppressed immune system, malformations of the heart, ears, hands, and feet. They rarely reach sexual maturity, and they tend to have a shorter life expectancy as well. That is the end of our chapter on growth, development, and inheritance. Thank you very much for listening and have a wonderful day. Bye.